last week, and Carol's much bigger than I am, so, you know. Okay, so application stuff, we're going to try and apply what we talked about this morning to real life, two things, particularly upper motor neuron disorders, which we started to talk about a little bit last week, and then I stopped and I said we'll talk about this next week. So it's next week now. So when we talk about upper motor neuron disorders, we're going to be talking about sort of a constellation of symptoms that can occur whenever there's damage to the tracts of the upper motor neurons that we just talked about today. Usually we're talking about the ones starting in the cerebral cortex, so that would be the corticospinal and the corticobulbar. But we know those pathways travel all the way down through the brainstem into the spinal cord. So while the most common causes of upper motor neuron disorders in adults are usually stroke, in children it's usually cerebral palsy, which we know is kind of a mixed bag anyway. We do see upper motor neuron symptoms in things like TBI, particularly if it is a brainstem, not brainstem, but a cortical injury. We'll see it sometimes in multiple sclerosis, some of these symptoms, because we're seeing demyelination of those upper motor neurons, of those motor neurons that are in the cortex. And remember, we get scarring in multiple sclerosis, and those neurons don't fire as well. And so we get some of the symptoms. The presentation is going to be different in MS, obviously, than stroke, but we're still affecting the upper motor neurons in some way. And we'll also damage those upper motor neuron tracts if we have a spinal cord lesion. So if we lesion the ventral horn, we're going to damage the lower motor neurons, those cell bodies of the lower motor neurons that live there. What are the two types of lower motor neurons? Alpha and gamma. Alpha and gamma. Okay, so they live in the ventral horn. Those are lower motor neurons. But those upper motor neuron tracts are coming and synapsing onto those lower motor neurons. So with spinal cord injury, we'll get a mixed bag. We'll get some symptoms that might look like upper motor neuron disorders, some that look like lower motor neuron disorders. And I think when I sat in on one of your fieldwork seminars last week, somebody said that their supervisor said, you've seen one spinal cord injury, you've seen one spinal cord injury. And that's why, because there's going to often be a mixed presentation in what you get, depending on the level of the injury, depending on just how these symptoms all play out. So again, when we talk about motor neuron disorders, sometimes you'll see this as upper motor neuron syndrome. I can't remember what term your book used. It's talking about a collection of symptoms that arise when there's disruption to those descending motor pathways, usually the ones arising from the cerebral cortex. And often the most common site for that damage is the internal capsule, either the posterior limb or the genu, because that's where our corticospinal and corticobulbar fibers are traveling. So stroke is usually the most common cause for damage to the internal capsule, although again a traumatic brain injury can do that as well. Now last week we talked about the difference between upper motor neuron lesions and lower motor neuron lesions, and I said that upper motor neuron lesions, the symptoms that we typically see are spasticity or hypertonia, hyperreflexia, and a positive Babinski sign. I didn't talk about clonus, I'll talk about that in a minute. But in truth, a true upper motor neuron lesion is going to have two phases. It's just that as an OT, you often will not see phase one. Phase one is sometimes called spinal shock, and it results when the lower motor neuron is no longer getting any input from the upper motor neuron. So the lower motor neuron suddenly loses all of its input, and it just stops. And what you see clinically is an immediate flaccid paralysis of those muscles that are being innervated by that muscle group. And you see a loss of tone and spinal reflexes. All right, so that's a lot like a lower motor neuron disorder, right? But within hours to days, this goes away, and the tone and the reflexes start coming back, and eventually become exaggerated. So it goes from complete loss to exaggerated hyperreflexes, hypertone, again within a matter of hours to days. So by the time you see them in acute care or whatever unit of the hospital, then they probably are already going to present with some spasticity or some hypertonia. If they don't, then that's actually an opportunity because those muscles haven't started to get spastic haven't started to contract, and you may be able to prevent some of that spasticity from forming, or some of the abnormal posturing that I'll talk about in the next slide. Clonus, how many of you seen clonus on fieldwork or elsewhere? So quite a few hands. Clonus is a rhythmic involuntary movement that's usually activated by a stretch reflex, and it's atypical. So we're not just talking about a stretch reflex, we're talking about an atypical response to muscle stretch that is involuntary and rhythmic, and you can see it in this video. And this is the ankle. It's often seen in the biceps as well.
This video will introduce you to clonus. Clonus is something that is seen in upper motor neuron lesions during spasticity of muscles and spasticity of nerves.
Oh.
To perform a clonus test,
okay. So
you want to
guys already seen
support
this?
the
No.
distal end of the lower extremity of the patient, and with
You
your
can
other
still watch
hand,
it.
you want to forcibly dorsiflex the patient's foot, like so. During an upper motor neuron lesion, in what's called clonus, the patient's foot will then plantar flex uncontrollably, almost in a tremor state, for so many seconds. You want to note if it's there and how many seconds it occurs in your SOAP note.
Okay. So good. There's some reinforcement of what you've already learned in another class. Have you guys already? Oh, go ahead, Tara.
So that has to be stimulated in order to make that go. It's not just like a twitch that you might get in your eye or something like that.
No, and it's different than the fasciculations that we saw in the lower motor neuron disorders that just kind of were involuntary muscle spasms. This is usually activated by a stretch reflex. So he was pushing into a dorsiflexion. Correct. So have you talked about spasticity with Al? Yes, okay. Well, let's hope that what I talk about is the same as what he talks about. So spasticity is tricky, and I have to say I did part of my master's thesis on this 15 years ago, and even then it was kind of like, nobody agrees on anything, and the research says all this different stuff, but in general, what we think causes spasticity is a lack of inhibitory control by those upper motor neurons, so that the upper motor neurons are no longer sending signals down into the spinal cord, and it causes two things to happen. One is that they're not influencing, normally they would influence, they would diminish those spinal reflexes so that we can have voluntary movements, right? That's what cortical spinal fibers do, they elicit voluntary movements. So they stop inhibiting the spinal reflexes from happening, or as much as they should. And so we get hyperactive spinal reflexes, especially the stretch reflex. We just saw that with clonus. But upper motor neurons also inhibit other muscle groups. So as they come down, for example, corticospinal fibers, we saw that they had a preference for flexors, for exciting flexors. At the same time they're exciting flexor muscles, they're inhibiting the extensors for that reciprocal inhibition. So we see a reduction in inhibition to other muscle groups as well. So we think that spasticity is caused by a lack of inhibitory control by the upper motor neuron. And by doing that, it's also decreasing the threshold of the lower motor neuron, causing it to fire more. Remember, if you have a lower threshold, you're going to fire more easily. So by taking away that inhibitory control, you're making it more easy for those lower motor neurons to fire. They're firing too much to certain muscle groups, which is going to cause spasticity in certain muscle groups. Is that in line with what Al talks about? Okay, all right. Well, good. At least it doesn't conflict. All right. How we talked about what spasticity looks like. So spasticity in certain muscle groups can cause abnormal posturing. So in this case, we tend to see spasticity or hyperactivity in the muscles of the biceps, which can cause elbow flexion and weakness or atrophy of the antagonist, which in this case is the tricep muscle. So when we have spasticity, we can have accompanying problems with atrophy of other muscle groups, of joint limitations in joint range of motion, to the point where we get contractures or fixations where the joints can't move. I think those are the two main things. So problems with range of motion, joint contraction, and atrophy in opposing muscle groups. And this is sort of classic presentation of stroke, upper motor neuron limb impairment, where we have in the upper extremity the shoulder slightly internally rotated or adducted close to the body, flexion of the elbow, slight pronation of the forearm, wrist flexion, a clenched fist, and the thumb inside the palm of the hand. So you can see that here. In terms of the lower limbs, we can see, again, flexion at the hip, adduction of the thighs. So you sometimes get scissoring of the affected leg over the non-affected leg. So you'll hear that pattern, that term, scissoring of the leg sometimes. Flex knee, stiff knee so that it can't extend. I'll talk about equinovarus and Winnis foot in a second, and flex toes. So again, is this consistent with what you talked about in Al's class? What are you doing in there then?
Define
Okay.
spasticity.
I'm probably getting this mixed up with something, but is the word, I guess, flexor synergy or something that comes to mind, or like what you guys?
Flexor synergy, yeah, is this idea of the flexors seem to be the ones that are spastic, and you get into these flexor patterns. So flexor synergy is another term that would relate to this. Real quick, the equinovarus and equinus foot. Equinus foot, it does mean horse, and I guess it comes from the idea that the horse's hoof points backwards or points downwards. I don't know. But essentially it is the top of the foot cannot dorsiflex or move towards the front of the leg. And so you get this, if somebody's ambulating on their leg like this, you get this like toe walking pattern, or they have to compensate by sort of shifting their weight back to try and get their foot down. But the foot is contracted or stuck in this position because of spasticity. What's that? They can't dorsiflex, right? With equinovarus, you get an internal rotation of the sole of the foot along with sort of this equinus posturing. In little kids, if they're born like this is often called clubfoot, which isn't an official diagnosis, but it's, you know, due to a neurological insult and an imbalance in these muscle groups. You can also get the same presentation after a stroke, so it's not just in children. Typically, you're not going to be involved in treatment of this. This is going to be much more in the domain of either an orthopedic specialist or a physical therapist, but the treatment for these conditions, in order to regain normal gait, or to attempt to regain normal gait or prevent real deformity, is going to be serial casting or splinting. So serial meaning you do it over and over again, so you would try and get just a little bit of range of motion and cast them in that position, and then as those tendons lengthen, you would take the cast off and recast until you approximated normal joint position or range of motion. It doesn't mean the spasticity goes away. They may have to continually wear a splint to prevent some deformity, but that would be the primary course of treatment, or surgical. If the tendons are too tight and you're unable to lengthen them, you may cut the tendon to try and get that range of motion and surgically repair the tendon. So it's a little outside the scope of what you guys would do, but if you're working with somebody and they have to maintain, you know, cleaning of the splint, or being able to take the splint on, or, you know, the cast, or taking the splint on and off, that might fall into the domain of ADLs, and that might be your route. So you won't have to do the splinting or casting, making the cast, probably, but it's good to know about it and to know what to look for. In terms of what you will do to regulate spasticity or to at least improve function post upper motor neuron lesion, there's several different things, and I've listed some of them here. And you know, just like there's kind of all this research about spasticity and what it is and what we do about it, you know, the treatment is not completely clear, and we don't know how to fix spasticity. There are a variety of treatment options. Some of them are, again, surgical, and that's not going to treat the spasticity, but it's going to help with the joint deformities. There are pharmacological things that we've already talked about, like Botox, that you can inject into the muscle, or some that you can take orally to try and reduce that hyperactivity of the muscle. Casting and splinting, again, is going to really not address the spasticity, but it's going to potentially influence the joint deformities that are caused by spasticity. And then we're going to talk now just about these two, which are EMS, electrical muscular stimulation, and transcranial magnetic stimulation. And these, again, we'll talk about what they do. They're not directly treating the spasticity per se, but they can help increase function of the muscle groups. So EMS, how many of you, well, first of all, electrical muscle stimulation, whether you put an F in front of it or not, is not the same as TENS. We talked about TENS like in week 2 or 4 or something like that. What was TENS used for? Pain management, right? Same idea, we're putting electrodes on the skin, okay, but different purpose. So TENS was used for pain management. EMS is going to be used to excite certain muscle groups. And in this case, the muscles are going to go directly onto the skin on top of the muscles that have lost cortical input or the muscles that are weakened because of the spasticity. All right, so if you're putting the electrodes on the muscles that you want to activate, the electrodes themselves are going to act like an action potential. They're going to skip that whole acetylcholine thing at the neuromuscular junction, and they're just going to excite that muscle and cause it to contract. All right, so it's going to replicate the action of that lost upper motor neuron. Again, mimicking the action potential, causing the muscle to contract, and eliciting motion in that muscle group. So in this case, you've got electrodes on the wrist extensors, which if you're stuck in a flexion posture, it's not the wrist extensors that are necessarily spastic, but they're the muscle group that's going to become weak because you're held in this flexed position. It's the flexors that are going active, 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 all right, and the extensors aren't doing anything. So you're going to provide stimulation to the extensors to try and get them to actively release, okay? So the purpose of EMS is often to prevent disuse atrophy in those muscles that are opposing the spastic muscles and to strengthen those weak muscles. And in this case, if we had an equinus foot that couldn't dorsiflex, you're going to put the electrodes on the dorsiflexors and try and get active dorsiflexion. Okay? And this is often done, so the functional, the FEMS, the F, it comes from function. So if we're just sitting here and we're having them do this with their foot, it's not particularly functional. But if we're having them do it in the context of reaching for, let's pretend this is something more functional, like food, okay, or a piece of clothing. Yeah, like Starburst or something. But, you know, we want to try and stay away from cones and stuff like that, but at least trying to elicit a functional grasp and a functional reach. That would be more along the lines of functional EMS, that you're doing it with task-specific practice. And sometimes that's referred to as RTP, repetitive task practice. So you're doing this movement over and over again with the hopes that it will become more automatic, that at least by releasing and strengthening these opposing muscle groups, you will be able to get active range of motion back. And there is some evidence that EMS can do that it can promote recovery, functional recovery after stroke. Again, it's not necessarily acting on the spasticity directly, but it's acting on those muscles that have become weak due to spasticity. And it's great if you can do this in a clinic. It's even better if you can take it and use it in real life. So some of you guys may have seen Bioness devices before, but this would be a wearable EMS unit that you could take home with you.
The H200 wireless hand rehabilitation system consists of two main components, a lightweight orthosis that fits over the hand and forearm, and a small hand-operated control unit, which communicate wirelessly, eliminating the need for troublesome externally worn wires and connectors, making the system simple and easy to use. The wireless orthosis provides both stability and flexibility to allow ease of movement while opening and closing your hand, and is custom fit to maintain optimal electrode contact. The control unit transmits wireless signals to synchronize the electrical pulses delivered by the stimulation unit in the orthosis. The pulses from the orthosis activate the nerves, stimulating the muscles that cause the hand to open and close at the appropriate time. Reach for the latest breakthrough in hand rehabilitation. Regain the freedom of performing daily activities with the Bioness H200 wireless hand rehabilitation system.
How many of you guys have seen the Bioness out in the clinic? A couple people. What'd you think? Cool?
I was at the VA for my field work when we were working on it for the polycompost.
Yeah. Look.
I got to try one on and it overpowered what I wanted to do. My hand closed it and I didn't want it.
Well, and it's supposed to compensate when people don't have voluntary movement. But yeah, what were you going to say, Dustin?
We just had, one gentleman we worked with, he had a lot of difficulty getting the electrodes to contact us, right, just because of, he had like long skinny arms, so it just like, kind of didn't really fit him very well, so he was difficult.
Yeah, and I don't know that much about them, whether they're one size fits all or whether they can customize them to fit better.
The ball
But
part switches out to different sizes.
you can.
Yeah, there's different pads on the inside.
I think you're going to get more in that next semester with Tony. I think you'll actually get to hook yourselves up, maybe not to the Bioness, but to do EMS on each other. So if you haven't gotten to do that already, yeah, Catherine.
What level, like severity of spasticity did this work for? Why do you see everyone with
Because they're expensive.
Right.
But yeah, probably somebody has severe contractures, so their spasticity has been so bad, they've been like this for 25 years. I don't know that the Bioness or that EMS in general is going to have a lot of effect on them. Ideally, again, you see these people, you start doing rehab a couple days after, stroke, after they stabilize, before the spasticity is really set in, before the joint contractures have formed. And I think you're going to see a lot better outcomes. But it'd be a good question, and let me just add to that. The research on EMS, I said that we do see some recovery, but if you go to the literature, the parameters for when do you need to start using it, how long do you need to use it to see results, what's the intensity, do they need to wear it all day long, or can they come in for an hour of rehab and it's going to be better? Like, those parameters are really flaky. Like, there's no, as far as I know, just manual. It says this is how you do it for this condition or this condition or this condition. So when you do this next semester in Tony's class, I think he has clinicians come in and do this with you. It'd be good to ask them that. Like, when do you use it? How soon after stroke do you use it? If they're 4 months out or 4 years out or 40 years out, would you use it? Like, those would be good questions to ask to the clinicians who are using this on a regular basis. One other thing that I wanted you guys to know about is transcranial magnetic stimulation. How many of you guys have seen this?
I haven't seen it, but
Okay.
I've heard it used for depression.
It is. Okay, so it is a treatment that is now considered evidence-based for depression and probably used most often with that condition. When I was in Florida at UF, the VA there was using it for stroke patients, and there is a fair bit of literature out there that shows effectiveness, again, for regaining function post-stroke.
Just a cool side note, there's a really cool documentary on Netflix that's called My Beautiful Broken Brain about a girl who has a stroke and then goes and does this and then has a couple of seizures from it. So I don't necessarily.
Way to ruin my talk! Just kidding.
It's really just because of
Okay.
it was really cool to watch.
Okay. My broken brain?
It's like My Beautiful Broken Brain. It's new on Netflix.
Okay.
So Netflix?
Okay. All right. Weekend watching. Yeah. I don't know if it causing seizures. I'm sorry. I would.
Maybe it wasn't caused by that.
Okay.
Maybe, I don't know. Maybe she's
Yeah.
She was having this though. She got
Okay.
it as a treatment.
It is really cool, and I think because it's relatively expensive, it's one of those things that hasn't caught on in all rehab units. But there is like I said, there's more evidence for this than there is for a lot of the things that you'll see when you go out on field work. So, but let me just describe it. Basically, it is non-invasive. That a magnetic coil is placed above certain regions of the brain. This is the coil here. And essentially, a magnetic pulse is sent down through the scalp to, and I have here depolarize. I think it can also hyperpolarize certain neural networks or certain areas of the brain, bless you, so that it can be used to excite or inhibit specific brain regions. And I believe in depression, and I can look into this more, I haven't done this, but I think in depression you're actually inhibiting those regions of the brain that are sort of sending those not so good thoughts. So I think it works through inhibition with depression. If you think about it related to stroke, it could go either way. You could excite those regions of, let's say, the primary motor cortex that have been damaged to try and get those remaining upper motor neurons working again. Or, and I think you see this in the video that I'm going to show, you can inhibit the non-affected side to try and get the affected side working again. So kind of like when we talked about constraint-induced movement therapy, if you're blocking one side, sometimes that can elicit motion and activation from the other side. So in terms of with stroke, TMS, or if you do it with repetitive practice, it's called RTMS, the treatment can potentially be effective. So we'll look at it here in the context of a research study.
Hi, Miss Patty here, with a few twists on an Easter dinner favor.
My name is Flavio Oliveira. I'm a neuroscientist at the University of California, Berkeley. I'm studying how people make decisions by looking at one of the most common decisions people make in everyday behavior, which hand they're going to use for an action. This happens hundreds of times during the day, where you decide that you're going to use your right or left hand to press an elevator button, for example, or pick up an object. And we don't normally think about this decision-making consciously, but our brain has to process a whole lot of information in order to make those decisions. In our experiments, our participants play a little game in a virtual reality setup where they have to reach towards targets with their hands, and they have to make a choice on whether they're going to use the right or left hand. And when they're doing this, when they're just about to make a decision, we stimulate their brain with this technique called transcranial magnetic stimulation, or TMS. What TMS does is it creates these magnetic pulses that penetrate the skull and hit the brain non-invasively and harmlessly, but it induces electrical activity that disrupts the function of a particular brain area that we're targeting. And as we stimulate participants' brains, they end up choosing to use one of their hands more often. So essentially, by stimulating the left side of the brain, for example, we're disrupting the planning of the right hand and making people use their left hand more often. So the future for our research, and hopefully other people's research based on our current findings, is that perhaps we can use different stimulation techniques to do rehabilitation of patients with neurological disorders such as stroke, or even just a better understanding of how decisions are made can help physical therapists, for example, develop better rehabilitation regimes to work with these kinds of patients. This is just the first step.
Or occupational therapist. So it's cool. I hope you guys, oh, sorry, go ahead, Ben.
So they say that's harmless and non-invasive, but firing all parts of your brain doesn't sound...
There really are no side effects.
Really? Okay.
No. Yeah.
Kind of a stupid question. Like, if this could help with depression, like when those people are going in and they're like shooting it in their brain to like influence which hands they're using, do you think they like?
I don't. I don't think the parts of the brain that they're stimulating in this, like what you just saw, are the same parts of the brain that they're going to stimulate when they're trying to treat depression.
So it's targeted.
It is targeted areas, and I don't. When I went and watched people, because I was thinking of trying to do this with kids with autism, and then I decided that's just crazy. But I spent a lot of time in the lab and was watching adults go through this. They spend several sessions mapping the brain and trying to figure out if we stimulate here, what response are we getting? And so, you know, this is beyond my level of expertise, but they do figure out where they need to place the coil on each person's brain. Because even in the brains we've looked at in lab, you know, your motor cortex is not in the exact same place as my motor cortex. We can't tell that by looking at the scalp. So the researchers do spend a lot of time with each subject figuring out where the coil needs to be placed in order to get the response that they want. Then once they have that map, every time the person comes in, they're positioned and the computer tells them where they need to place the coil. But it's going to be different based on what you're trying to target. target. So if you're targeting depression, the coil's gonna be someplace totally different than the motor cortex. Yeah.
Is there anything being done with autism with this? I know someone that's in a clinical trial.
There may be, I don't know. Doing TMS?
Well, he has Asperger's, but they're doing it for like emotional / anger regulation.
Okay.
But
I wouldn't be surprised. People are trying it with a lot of different things. But A, you would probably need a lot of money to do that study, and you've got to have the right kind of kids, because this is, I mean, you have to
Well,
sit
he's
for a
not-
while.
he's not a kid.
Oh, he's not a kid. Okay, maybe with adults. Then.
Yeah.
There is a click that goes on, like every time they send that pulse, and I just think our kids be what, you know, like really like startle to it. And you have to sit really still for a period of time. Well, unless you're doing like again like a repetitive like a task, but your head and your body has to be relatively still for that coil. So as you know, the Caitlin's and Anthony have seen some of our kids like in our research, trying to get them to sit still, period, even with a portable unit on is difficult. It's hard to imagine like them holding their head in that position for any period of time. So yeah, I think it would be interesting to do this with kids with autism, but it'd be hard.
What part of the brain would you target with kids with autism?
I don't know. I mean, if we're talking about mirror neurons, maybe you're trying to activate that premotor cortex. Also, you know, there are, in fMRI studies, like decreased connectivity from the parietal regions up to the frontal regions, so maybe you're trying to activate that. So yeah, I didn't have that completely planned out when I was thinking about it. I ditched that idea fairly quickly. Yeah.
So I, like with the action, it's obviously kind of an immediate, stimulus and then result, but for like depression or anger, is there a long-term effect, like if you're hooked up for so long, or?
Yeah, if you guys are interested in it for depression, go on YouTube, because there are a couple videos explaining how it's done with depression, and I'm not trying to ditch your question, but what I can say is that, let's say you were doing therapy and you were telling, like part of your therapy for depression was to say, you know, like, I am tall, I am tall, I am tall, like some sort of positive self-talk. Essentially the TMS can, let's say in an hour you can say that to yourself like 300 times maybe. In an hour of TMS you could probably get 50,000 of those repetitions in. So the idea is that by doing the TMS, you're repeating this way more times than you could in like a real, I don't know, doing this in another way. So that the number of stimulations or the number of times that part of the brain gets activated is going to be way more than what you would get in other types of therapy.
So could it like promote dendritic growth for those pathways? Are they trying to like promote the pathway? And if we need to pass up on this one, okay?
Yeah, I don't know the answer to that. I assume that they're hoping for some level of dendritic growth, especially if we're talking motor and you want to get active voluntary movement back, something has to be happening. But again, I don't know the research about that. But yeah, something to keep an eye out for. It's pretty cool. Okay, if we do not get recovery of that upper motor neuron, the real estate in that area of the brain will not go to waste. So we've talked about plasticity in the sensory cortex. It really is about the same when we talk about plasticity in the motor cortex. So if we look at figure A, we see this is from a rat motor cortex, and we see representation for areas of the forelimb, of the vibrissae, which are the whiskers, and the periocular or the motor muscles around the eye. So that in the regular rat, if we stimulate any of these regions, we're going to elicit movement in the corresponding regions. And in this study, again, this is really similar to what we saw in the sensory lecture. In this study, they cut the upper motor neurons controlling the whiskers, the purple here, and over a period of a few weeks, we see that after the injury, the part of the cortex that had been controlling movements of the whiskers is now going to be responsible for controlling movements of the forelimb and muscles around the eye. So it's that same concept of neuroplasticity, but applied here to motor pathways, motor cortex, as opposed to incoming sensory information. Go with that? Anything new? I wanted to, and this is where the lecture kind of stops being cohesive because we're not talking about spasticity anymore, but I wanted to throw out one more condition that is an upper motor neuron lesion. And I said last week we looked at progressive bulbar palsy, and I said don't get it confused with pseudo-bulbar palsy, which we'll talk about next week. It's next week. This is pseudo-bulbar palsy. And remember when we talk about bulb, we're talking about the brainstem. And so pseudo-bulbar palsy is a lesion of the corticobulbar fibers that innervate motor nerves, particularly 10, 11, and 12. And the most common cause of this is, again, a stroke to the internal capsule. But remember, corticobulbar fibers travel in the genu, so that bend in the internal capsule. So the most common cause is going to be a stroke in that bend of the internal capsule. And remember, progressive bulbar palsy was a lower motor neuron disorder. So we saw weakness, we saw muscle atrophy, we saw flaccidity and hypo-responsiveness, because those are all characteristic of lower motor neuron disorders. So in pseudobulbar palsy, we have an upper motor neuron disorder, and so we see upper motor neuron symptoms. We see an exaggerated gag reflex, an exaggerated jaw jerk reflex, which we normally wouldn't see at all. The tongue, instead of being weak and flaccid and atrophied, is going to be spastic, and it's going to have difficulty protruding from the mouth. And the speech, remember, in progressive bulbar palsy, the speech was very nasally. In pseudobulbar palsy, the speech is gravelly and not well controlled because you're having spasticity in those muscles around the face and the tongue. And similarly to progressive bulbar palsy, you can see difficulty over time with the ability to speak, chew, and swallow. So that is a commonality between the two disorders. I'll show a quick video. This is the only one that I could find, and it's not great, but at least you can hear the gravelly quality to his voice, and you can see some of the difficulty with the tongue protrusion. And what I would expect is when he does protrude his tongue, that there might be a bias to his tongue going towards one side because of what we learned today. But I don't know with this condition whether or not both of the motor nuclei for the hypoglossal nerve are affected or not. You'll see with him he has a hard time protruding, but it doesn't necessarily point in one direction.
All the way out. Keep it back and forth.
So he's having to compensate for his tongue movements with a lot of extra mouth movements.
La 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 la. Say pa pa pa. Pa pa pa. And say ka ka ka. Ka ka ka.
You hear that gravelly quality?
Ka. Catch. Catch. Okay. And just relax a little bit with your jaw. Just relax totally, let it go close. So there you go. Open this a little bit. Okay. You have a positive jaw turn.
And it's hard to tell that from the video. You can see it more if you look on the back of his jaw.
Okay.
Anyway, main thing to remember in distinguishing these two conditions is just to remember that pseudobulbar palsy is an upper motor neuron condition, so you're going to see spasticity and hyperreflexia. Progressive bulbar palsy is a lower motor neuron condition. You are going to see weakness, flaccidity, and hyporeflexia. Okay, yeah.
Could you see this in conjunction with cerebral palsy, since cerebral palsy is kind of a catch-all?
You could see this in conjunction with cerebral palsy because it is a catch-all. So you could see upper motor neurons or corticobulbar tracts affected in cerebral palsy. Okay, last thing of the day. We're going to talk a little bit about apraxia versus dyspraxia, or about both of these together. Have you heard the term apraxia in your adult classes yet? Yes, a little bit. What, he just defined it? All right, I won't pick on Al. He's my boss. So. Okay. Carol's bigger than me, and Al's my boss. So. Apraxia is a term that is more commonly used with adults, so you'll hear that in the clinical realm of adults. And it is usually said with reference to adults that have had a specific brain lesion that affects their ability to perform complex movements. So we're not talking about just the ability to, extend the arm, but the ability to plan something more complicated, like extend the arm, grab the toothbrush, and grab the toothpaste with the other hand to put the toothpaste on the toothbrush. Like a multi-step complex action. So there's a deficit in the ability to plan and execute complex motor actions. And so praxis is that motor motor planning. Apraxia means the absence of praxis. And so again, with adults that have a brain lesion, you may see a complete loss of the ability to do this, or more likely you'll see problems with praxis. But apraxia is the term that's more commonly used with adults. With children, we typically use the term dyspraxia, so a dysfunction with praxis versus a complete absence of praxis. And we define that as a difficulty in planning and executing movements. So again, they're able to walk and talk and do things, but when you ask them to do something like skip or jump rope or get dressed in the morning, those more complex, more multi-step, more bilateral type activities are much more difficult. And with children, because we're not talking about kids that necessarily have cerebral palsy and have a brain injury, we see it with kids that have often more typical overall development. And so oftentimes it's thought that this type of dyspraxia has a sensory basis. And that's because of this loop that we talked about earlier, where this posterior parietal cortex sends all of that integrated sensory information to the motor planning centers of the brain. And so what research has shown is that kids that show up with dyspraxia often have deficits in particularly somatosensory and vestibular processing, sometimes visual as well, and that is thought to influence motor planning through these cortical loops. Right, so slightly different terms, both kind of relating to the same thing. One intervention that I hope you get to see for adults with apraxia is mental imagery. And there's a lot of research that's come out recently for the use of mental rehearsal or mental imagery. And this is the idea of practicing a motor pattern, such as reaching for a starburst, in your head prior to executing the movement, or prior to being able to even do the movement. So if you have somebody with spasticity or joint range of motion or whatever, and your goal is to get them to reach for that starburst, but they're contracted, they can't do that, one of the things that you can start doing is having them practice that in their mind, in their brain, without actually executing the movement. And the idea is that this mental practice elicits the same type of neural response that we see when they actually physically do the task. And this is because of those mirror neurons in the premotor cortex, right? So that this premotor cortex is going to fire even before potentially, or in the absence of, actual movement. So the thought is that if you repeatedly practice the event in your mind, it's thought to increase skill reacquisition, especially post-injury. And the research says that mental practice combined with repetitive task practice is the most effective, so that if you rehearse it and then you practice doing it several times, that's going to be even more effective than either mental practice or just doing it several times alone. So there seems to be this added benefit to mental rehearsal. And mental rehearsal can either be me saying to myself, I'm going to extend my hand, picturing what this looks like. More often, it's actually audio or video files of somebody else, either an audio file of somebody walking them through it repeatedly, or a video file of somebody doing the action that you want that person to be able to do. So as an OT, you may be developing those types of video files that somebody can watch on their phone or watch on their iPad, even when they're not in therapy, so that when it comes time for them to practice that task, they will have already rehearsed it several times, and therefore, hopefully, be better able to perform that skill when the time comes. And remember that premotor cortex, that PMC, sends corticospinal fibers down. It's not just coming from the primary motor cortex. So again, this is thought to be an effective piece of neurorehabilitation following a stroke. And this is that study that I kind of referred to earlier, and maybe would have been better in the first lecture, but this is where some of that research is coming from with motor neurons. And so in this example, the monkey is picking up, I think it's a peanut, and you can see these vertical lines are the activity, the neurons firing in the premotor cortex, either before or during the actual movement. And then that same pattern of activity occurs even when the monkey watches another monkey pick up that peanut. So his hands aren't doing anything, but we just get that same pattern of firing. It's that same activation when he watches the human pick up the peanut. But in this case, all he sees are the forceps, or the tweezers, picking up the peanut, and we really don't get that activation. So it's thought that these really are looking at the motor patterns, particularly for things like reach and grasp, and our ability to experience the actions of others, and to understand what those experiences are. So again, this relates to the treatment of, or the use of mental imagery in treatment, and the idea that mental rehearsal is going to give us similar activation to actually doing the task. Does that make sense? Tie it together a little bit? I know you're dead. Okay. Last slide, I promise. All right, dyspraxia in kids, there is a slightly different rationale for doing treatment A, because you're not assuming that a part of the brain is disordered. Maybe that parts of the brain are disconnected. And so if you think that there is a sensory basis to the dyspraxia, then oftentimes a sensory integration or a sensory-based approach might be what you take. And in that context, you would enhance the sensory features of the environment and the movement experiences, and work on visual, somatosensory, and vestibular integration. And so you might have the child moving on the swing and trying to time and plan his execution of putting the ring onto the cone. So timing, sequencing, planning are all part of that task, and then within the context of SI, you'd be grading that activity to make sure that that child's successful. How fast can the swing be moving for him to do it? How far away can the cone be? How heavy are the objects that he's holding? He's going to get more somatosensory input if the objects are heavier. So you're thinking about it from that perspective. Other approaches that we'll use with kids with dyspraxia, even kids that have a sensory-based dyspraxia, are cognitive approaches. So you'll learn about co-op next year, but this is sort of a goal, plan, do, check. So you say, what is your goal? I want to be able to get on my bike or ride my bike. And you get them to go through a plan. Like, how are you going to do it? When you're holding your bike, how are you going to get your leg over? How are you going to get started? How are you going to push off? And you'll break that down into as many steps as you need to. You'll have them try their plan, and then you'll see how it went. If they said they're going to get on their bike by hopping with 2 feet and sitting on the seat, you could say, all right, let's go ahead and try it. It's probably not going to work, but that's where you're going to go back and say, you know what, that didn't work. Is there another thing that we could try? And so that type of cognitive approach is not going to necessarily fix if it's an underlying sensory problem, but it's going to get them in every situation to try and think through a solution, to try and cognitively motor plan in situations that it doesn't come naturally. And more we're seeing mental rehearsal. So just like we saw with adults, but with kids, like you're going to go through an obstacle course, let's think about this. What are you going to do when you get to the balance beam? How are you going to walk on the balance beam? Picture that in your head. Go through that. So again, similar concept for why we might use it. It might be used slightly differently with kids than we do in adults, but the same kind of concept. And I think that's it. Any questions before we go? Yeah, Martha?
If a child's their motor cleaning problems are from cerebral palsy, would it be considered apraxia?
You're probably more likely to hear apraxia than dyspraxia, yes. Okay, have a good week. Remember, there's a quiz next week, and it's on the lower motor neuron lecture stuff that we did last week, and then lecture and lab from today.